As I said before, we talked about the benzodiazepines, we talked about barbiturates and the 50s agents. Now let's talk a little bit about non-benzodiazepine, non-barbiturate anti-anxiety drugs. Some of this is review. I'm going to put this in the context of new uses for older drugs, and then also some actual newer drugs. In terms of new uses for older drugs, there are two kind of levels. Like I said, we've discussed some of this already. We haven't talked much about it, but there are, of course, noradrenergic drugs. Propranolol is a beta blocker. Clonidine is an alpha-2 agonist, sort of an autoreceptor agonist, if you will. And they were talked about in autonomic pharmacology and maybe to a certain extent in the cardio module. These compounds have the capacity to diminish noradrenergic neurotransmission. The propranolol blocks the receptors on the postsynaptic side. The clonidine more or less suppresses the activity and the release of the norepinephrine from the presynaptic neuron. They're useful in some situations of anxiety. Propranolol is probably most noted for its potential to work in kinds of phobic anxiety. We talked about phobic anxiety being a situation where a particular event or a particular situation, maybe it's a social situation or a performance kind of a thing, maybe it's a situation of snakes or heights or elevators or whatever. There's a certain amount of anxiety with that. Individuals can get some relief with propranolol. Perhaps the most noted application is sort of across the street on Woodward. There's probably, when the DSO performs, there's probably, I think the best estimates are that about a quarter of those musicians are taking Inderol, and they don't have a heart condition. They want to steady their hands. They want to slow their heart from racing when their solo comes up. And that's sort of an application of sort of a specific kind of phobic anxiety. We've already talked about serotonergic and noradrenergic drugs in terms of tricyclics and MAO inhibitors, SSRIs and SNRIs, so we won't talk about those. Let's move on to some newer drugs. The newer drugs primarily work at serotonin receptors, and in this list there'll be drugs that work and drugs that don't. Buspirone is an example. It's about 30 years old now. Buspirone, the primary application is anxiety. I won't talk about Zofran, which is not an effective anti-anxiety drug, and then we've already talked about the SSRIs. But we'll talk about Buspirone for a little bit. Oh, I guess this slide's out of order. This is more a historical kind of perspective. I think I mentioned this already. We'll touch this anyway. In the 1970s, benzodiazepines were out there, were used a lot, Valium, Librium, maybe a little Xanax. Very effective anti-anxiety drugs. Not particularly great against this new thing called panic disorder, which was being identified by some of the psychiatrists. The psychiatrist Donald Klein made an observation that tricyclic antidepressants work to reduce panic attacks. And that was like earth-shaking, because there was nothing out there that could treat these patients, and all of a sudden they get phenomenal responses with antidepressants given chronically. They followed that up with demonstration that monoamine oxidase inhibitors work. They also then went and, when SSRIs came out, there was the discovery that SSRIs also reduce panic. And eventually someone said, well, geez, these are great anti-panic drugs. Do they work against the generalized anxiety disorder as well? And there were some studies that looked at that, and lo and behold, antidepressant drugs of the tricyclic, of the MAO inhibitor, and of the SSRI, and even the SNRI compounds could reduce generalized anxiety disorder. Here's the rub. They still require 4 to 6 weeks of chronic treatment, much like the treatment for the antidepressant action. So if you're an anxious patient, you can pop a Valium and feel better in about an hour and a half, or you can take some Prozac or some imipramine for 4 to 6 weeks, and eventually hope your symptoms will be abated, will be reduced. That's a tough pill to swallow, but there is a reality that with the benzodiazepines, there is a much greater likelihood of becoming addicted to the compounds, becoming an addict. Mother's Little Helper is a reference to benzodiazepines. And if you look at the lyrics of that song, you'll see that it's not all good. It really speaks to addiction to the benzodiazepines. Buspirone was introduced in the 1990s. This was after antidepressants came out, and the notion was that maybe we can manipulate serotonergic neurotransmission and get an anti-anxiety drug that is a little bit better than the antidepressants are. Buspirone is fantastic in the sense that it doesn't produce much sedation. It's not so fantastic because it gets kind of mediocre scores as an anti-anxiety drug. I think there's a sense that if you really need to treat the anxiety, Buspirone might not be the most effective drug. This is particularly true in patients who've already had Valium before. And whether that's because they recognize their good old friend Valium and the little buzz it gets them, and they don't get that from Buspirone, or whether it's not dealing with the anxiety, those are things that you just can't quite discern sometimes. So we'll talk a little bit about Buspirone. Anxiety, it's its primary use. It's not an antidepressant. It was thought of as a potential antidepressant, but it doesn't seem to work. This just shows that the chemical structures are quite different. Buspirone is an azopirone class, and benzodiazepines are certainly not that. In terms of the pharmacology, Buspirone does not interact with the GABA-benzodiazepine receptor complex. It couldn't find it. If you had it in a small room, you wouldn't be able to find the benzodiazepine receptor and bind to it anywhere. It doesn't have an effect on reuptake blockade. It's not like a Prozac or a Zoloft or something like that. It's not an MAO inhibitor. It is what it does. What the pharmacology that we do know is it's an alpha-2 antagonist, kind of like a yohimbine kind of a product. It's a D2 dopamine antagonist, and that has the potential to work at the autoreceptor, and there's also a postsynaptic dopamine receptor. Probably the most important action is its effects on the 5-HT autoreceptor. It's a partial agonist at 5-HT1A receptors. And there's some evidence that it's not the Buspirone itself, maybe it's the metabolite, the 1-PP active metabolite. But essentially the best evidence is that Buspirone works to reduce anxiety by virtue of some long-term treatment at 5-HT1A autoreceptors. We already talked about it in the context of being an augmenter, and that's probably how it serves as an augmenter in the treatment of depression when combined with, for example, an SSRI kind of a drug. Buspirone does have a delay to onset, which makes it undesirable compared to perhaps Valium, but it has probably zero addiction liability. I don't think there's a market out there for Buspirone. I don't think anybody has ever said they get high on their Buspirone. It's not a benzodiazepine, so it has no sedative, no muscle relaxant, essentially no CNS depression. When it first came out, there were commercials, advertisements in the Archives of General Psychiatry that basically showed people in a cocktail party setting kind of saying, well, you can have some Buspirone now too, because it's not going to interact with alcohol. It's not euphoric and not addictive, like I say, in all the ways that it's been possible to study it. There's not a whole lot of evidence that Buspirone makes rats or cats or humans high. Some of the concerns, one is it's if you've been benzodiazepine experienced, you're going to be disappointed, I think is the one way to put it. Or another way to put it is you get the best results in newly diagnosed patients. Another concern is that if the patient is being transferred from a benzo to Buspirone, if you're concerned about benzodiazepine drug withdrawal, Buspirone does not prevent that, block that, or reduce that in any way. And then the last thing, I mentioned this already, there are really some concerns about the actual efficacy of Buspirone. Is it really that good an anti-anxiety drug? So that's the Buspirone story. The ondansetron story is an interesting story. I'll tell you the bottom line here is that ondansetron is not an anti-anxiety drug in the classic sense. Ondansetron Zofran is part of a group called 5-HT3 antagonists. These were developed in the early 1980s. And the sense was, this was when there was sort of an expansion of the number of 5-HT receptors that were sort of in our bodies and in our brains, and development of some drugs that might be able to tap in and specifically change one or more of those pathways. Ondansetron Zofran was developed in the 80s and introduced then in the late 80s. It was as an antiemetic, and it's an incredibly potent and selective blocker at 5-HT3 receptors. And this is a tried and true way to reduce nausea and emesis. For example, in cancer chemotherapy patients, in AIDS patients, a lot of patients who are going to have nausea and emesis, 5-HT3 antagonists are very, very effective. It was tried as an anxiolytic, as an anti-anxiety drug, because what happened when it first was used for cancer patients, they said, I'm not throwing up and I just feel great, I'm not anxious at all anymore. And there was a concern, well, are you not anxious just because you're not anxious, or are you not anxious because you're not throwing up anymore? And the bottom line is that if you took non-chemotherapy patients who had anxiety disorder and you gave them ondansetron, you gave them Zofran, it doesn't work. There's no evidence that 5-HT3 antagonist compounds will reduce anxiety in ordinary anxious patients. It reduces anxiety only secondary to the antiemetic effect. So they're not effective as anti-anxiety agents alone. So that's the anti-anxiety drugs. We'll try to summarize. Antidepressants, particularly SSRIs, but it's not limited to the SSRIs. They're used with chronic treatment. They're used against panic disorder. They have effects against generalized disorder, maybe others as well. Benzodiazepines really have been the mainstays since probably 1960 when Valium and Librium came out. They're mainly used against generalized anxiety. There's some antipanic, some antiphobic, but really the majority of these drugs, benzodiazepines, are used. The majority of benzodiazepine therapy is focused on generalized anxiety. There are a lot of side effects and other problems, potentiation of sedative effects, sedation itself, addiction, tolerance, dependence, withdrawal. Those are all problems, real-world problems with benzodiazepines. There are potential new benzodiazepine therapies. We talked about them a little bit, some of the potential for partial agonists. We have the benzodiazepine receptor subtype specific ligands, the primarily sleep aids, those opiclone kind of compounds. There are other benzodiazepine GABA ligands, barbiturates in the 50s agents, and alcohol. They all have limited utility as anti-anxiety drugs. They sort of feed into this GABA A benzodiazepine receptor complex in some way. But because they're not antagonized by the romazicon compound, they're a little bit riskier to use, obviously. Then there are anti-anxiety effects that are not mediated by the GABA benzodiazepine receptor complex. As I said before, the adrenergic drugs like clonidine and propranolol, all of the antidepressants basically work sort of independently of GABA benzodiazepine receptor complex. Buspirone works primarily or most likely as a 5-HT1A partial agonist. And then ondansetron, which is not really an anti-anxiety drug. And that is basically the story. And as you can see, this is an amazing finding. I think we found a time warp here. It's still only 9:59 on Wednesday. So I think you can fairly and honestly say that this lecture finished in a minute early, even though we added a lot of information at the very end. But for that, I would say have a great great Labor Day weekend, and we'll see you back on early in the week. Bye now.